All right, I think we're at 7 o'clock on the dot, so I think we'll go ahead and get started. We may have a couple of others join us here in the next few minutes, but we'll go ahead and get started so we can stay on time, okay? My name is Mike Wilson. I am the co-chair of the webinar committee for ARIN, and I'd like to welcome everybody to tonight's webinar entitled Building a Better IR Team, RTs, RNs, and Mid-Levels. Before we get started, I'd like to just give a few announcements before we begin. We do have our next webinar, which is scheduled for December 10th. We will have Kathy Duncan, who many of you may know from previous conferences. She's going to be speaking on medical management of patients with anxiety, claustrophobia, and panic attacks. So it's going to be an interesting one. I hope that you all can join us for that as well. We also, in January, we're hoping to get a confirmation from a physician who is planning on providing an update on Ebola. So the date at this point is still pending, but we're hoping that is going to be lined up here in the next week or so. Tonight's webinar, or tonight's activity, has been approved for one contact hour of CE by the Georgia Nurses Association. This webinar is being recorded for an on-demand viewing. The on-demand version will be housed on a private YouTube channel and can be viewed on an iPad or an iPhone as well. Participants for the live webinar will also have access to the on-demand version as well. If you have questions for our speaker tonight, we ask that you hold those questions maybe until the end of the presentation, and then we can kind of go back through and Gail will be able to answer those for you. The disclosures for tonight, the planning committee and the speaker have no disclosures. So I'll get right to it. We're going to introduce Ms. Gail Egan. Gail Egan has been a registered nurse with over 35 years of experience, the past 20 years as an adult nurse practitioner. She has extensive experience in lecturing to a wide variety of physicians and radiology technologists and registered nurses in radiology. Gail has presented at the Society of Interventional Radiology, the Association of Vascular and Interventional Radiographers, and the Association for Radiologic and Imaging Nursing. Gail has multiple publications to her credit on vascular access, interventional oncology, and radiologic team building. So with no further ado, I'll go ahead and turn it over to you, Gail, and thanks again for doing this for us tonight.
Oh, thanks, Mike. I really appreciate talking with you all. We did this presentation first, I think, about a year ago at the AVIR meeting, and it was really fun to talk with everybody and get everybody's perspective on how teams work in IR, sometimes how they work well and sometimes how they work not so well. But the bottom line is none of us could do it by ourselves. So greetings from now sunny California, where it's about 60 degrees and people here are walking around with winter coats on. So it's sort of strange. But anyway, so, we talk about how many people it takes to run a case in IR, and sometimes it's more and sometimes it's less, but there are always at least 3 people, the main operator, who could be a physician, a nurse practitioner, or a PA, and sometimes an RPA, the patient, and an RN and an RT. So I guess that's 4 people if you count the patient, right? And that seems to be the team that we think about most of the time, the sort of key people that can make this happen so that the patient gets what they need. But there are some other people on the team who are easily forgotten. And you think, who are the other people that make it so that we can do our jobs, right? There's a lot of people that sometimes we forget about, like the housekeeper, the person who is cleaning the floor and wiping all that blood off the II when we're splashing it around in a TIPS case. The scheduler who made it happen and figured out the patient's insurance and made sure the pre-approvals were done and that the patient got to the right practice site at the right time, the patient had directions, those kinds of things. The people who registered the person as they first walked in the door. And I think these people are so often forgotten about, but they're key to the patient having a positive experience. When the patient walks in and someone is nice to them and says, welcome, we're going to take care of you. You may say, I'm sorry you have to be here because nobody really wants to be here as a patient, but we're going to take good care of you and we're going to get you through this. As compared to somebody who's sort of gruff and, the patient walks in the door and they're sort of confused. One of the things that frustrates me about healthcare institutions all the time is that something as simple as finding the front door is often difficult. If you go to, say, the Marriott Hotel, it's pretty obvious where the front door is. But you go to some of our bigger hospitals where one building has been added on to another, and people don't even know where the front door is, much less how to get to radiology, which, of course, oftentimes is in the basement, and that doesn't feel like a real good thing if you're a consumer. Some of us have PCAs or patient care assistants, like a medical assistant, those kind of folks who make sure we've got our linen on the table, that the patient is changed, that the patient gets to the bathroom, those kinds of things. So all these people not only help us do our job, but contribute to a positive experience for the patient, or negative if it doesn't go so well. To lay on getting the next slide up. I'm sort of curious. But anyway, so you ask yourself, can you do it on your own? And sometimes, we get sort of impatient maybe with the way the day is going, and, there are a lot of cases stacked up, and you think, I'll just go do this case myself. I can do it all by myself. And then you have to ask yourself, is that really the right thing to do? Like, technically, maybe you could do it. You go up, say, to the inpatient unit, and you do a paracentesis. And the equipment isn't that complicated, and maybe the patient's, got a large amount of ascites, and, you can process the paperwork and all that kind of thing. But you have to ask yourself if it's really the right thing to do. Even in the simplest cases, sometimes things can go wrong. The other thing I think is I never want to underestimate the value of moral support, and I mean that moral support for both the patient and the operator. We've all had those times where we've been in the weeds, we're having trouble with a technique, and we call for one of our partners and say, hey, can you come in and help me? I don't know how to transfer this image over, or I'm not sure what to do next. This wire I'm working with won't work. And we call for one of our peers. And when the peer shows up in the room is when we get it to work, before they've even given us any advice or done any hands-on with the patient. And I always find that such a curious thing, the power, I think, of moral support and knowing that someone's going to have your back at that difficult time in a case. I've been in interventional radiology about 18 years, and I came from an oncology and bone marrow transplant background. And let me tell you, even though I knew how to use Access as a consumer, I didn't know how to put anything in except for PICC. So I had a lot of techniques that I learned, especially from RTs. I couldn't have told you what a Benson wire or a Coons wire was when I first walked in the door, but now I know those things and can teach it to someone else. But you folks are the people who taught it to me initially. How many times has somebody suggested a strategy to you? How about take that dialysis catheter, stick an 18-gauge needle in it, and put the wire through the 18-gauge needle instead of cutting the catheter open and doing a cut down. Brilliant, right? But somebody else taught it to you, and it's not something that you would necessarily think of to do yourself. All the time I know that a successful case is the result of input from different people on the team, whether they be RNs or RTs, who've suggested a particular strategy, or push harder, or turn this way, all those kinds of things, just because they had that experience or just had that idea. So oftentimes a patient will say to me at the end of the case, thank you, or someone, and I tell them quite honestly, this is not something that I could do myself. Maybe it's something as simple as sedating the patient. Lots of things we couldn't do if we didn't have that. So I fully understand that my ability to perform is dependent upon the other folks in the room. I also understand that many times I've been in the hole and you guys have bailed me out with a suggestion or by getting me some assistance or whatever it is. And I'll never forget it. When I first started in IR, there was a tech named Jimmy, and Jimmy's in Pennsylvania now, and I don't know that Jimmy's on or Jimmy's still in IR, but Jimmy was instrumental to me in having a successful career in IR. And not only did Jimmy teach me technical things, but far more important is Jimmy helped me believe in myself. So when I was new and I felt very incompetent and I didn't know what I was doing in terms of a particular procedure, I would walk in the room and Jimmy would always say to me, this is going to be great. We're going to be out of here in 15 minutes. We're good to go. And little things like that really made a big difference in me learning and getting through a case. So the bottom line, and you've heard it before, is that the team is really greater than each of us alone. And sometimes I'll say to patients, together we make a whole brain. But I really do believe that that's true. So what are some of the key characteristics of a team? Well, first, we have to have a reason to be together, right? I mean, teams aren't necessarily so easy to be a part of, and sometimes you think, oh, I could do it faster myself, but there's really a reason for us to be together, and that's to work stronger and better together. But we need input from each of the members of the team. We all know how morally sort of degrading it is to have somebody on a team who doesn't really want to be on the team or even wants to pull the team down. Very demoralizing. If each person contributes their experience and knowledge, we can get a lot further. And if each person really believes that being part of the team together makes a difference, that makes a big difference. We should all want to be successful as a team, and that is together we'll do better than we would alone. The bottom line, though, is we need to be held accountable for what we each do. So each of us as individual members on the team and then the performance of the team as a whole. So what are some key roles of different team members? Well, contribute is a big, important one, and it may seem like very obvious. You say, well, of course, everybody needs to contribute. But you can pull a team together, and sometimes people are put on that team either by choice or because they've been asked by a manager or someone else, or they've been assigned to it, and they may not necessarily be so happy to be there. So you really want to motivate everybody on your team to make a contribution. And contribution can be criticism of the way we currently do something, as long as it's constructive. Each person needs to accept ownership for their role. None of us knows every role on the team. I'm not a good manager. I know I'm not a good manager. I don't want to be a manager. So I really appreciate that if there's a manager on the team, the manager knows how to manage resources and get the things that we need to do the job. I know that I am not good at that. Each of us should be a salesperson, and that is a salesperson for IR, a salesperson for the team, a salesperson for the patient, and for the institution. Okay? That this is going to be a good experience. Word of mouth is a very, very powerful marketing tool. And why is that? Because there's no perceived conflict of interest. That's why it's far more powerful than print or internet advertising. Sometimes people worry that if they share their expertise, it means that they're going to lose something in some way. I find that sort of a curious thing, and I think it's important that each of us has expertise and learns in our career, but I think that it really is not that meaningful until we pass it on. Someday, most of us are going to be consumers of healthcare, and we're going to need the techniques and tools that we've all learned. So I really do think we have a responsibility to pay it forward and teach someone else the tricks that you've learned. Make it easier for that next patient. Operating within the roles is an important thing that I think we underestimate a lot. And basically what I mean is if you agree to do something in the team, in a room, in a meeting, or in a case, you do it. You don't agree to do it and then go outside the room and complain to someone else and usurp what the team is trying to do. Sometimes this makes people feel better. They vent. Maybe they really disagreed and didn't feel comfortable bringing it up in the team. At the time, but you've got a responsibility to do that at the time. And if you don't bring it up at the time the decisions are made, then I really don't think you have a right to go outside and criticize to someone outside the team. You need to sort of put on the big girl pants and deal with it at the time. Feedback is really important, positive and negative. People make mistakes. That's why there are erasers on pencils. So oftentimes we can just say to each other, you know what, I was in that jam myself, and here's how I learned how to get out of it, or here's what I did. Maybe, if you want to try that next time, just an idea. That's a good way to propose a change in practice to people. We need to alert each other to any threats to the team. That is, you know what, we just used the last tunnel hemodialysis catheter on the shelf, just giving you a heads up. We need to get some in and overnight ship them, whatever. Participating fully, I think we really talked about. Definitely want to work through conflicts. If you have an issue with someone on the team task, the way the team is working, bring it up. Bring it up. Nothing is gained by not bringing it up. And each of us should assume the responsibility to lead the team whenever necessary. There may be an assigned team leader. For instance, the physician is typically the team leader during a case, but sometimes other people will take leadership roles as well. So be willing to do that depending upon what the issue at hand is. For example, if there's an issue with sedation, then the RN in the case should be the one who's providing leadership on that particular issue. So there are three basic elements for success in a team, and I'm going to go through each of these, and they're engaging, enabling, and energizing. So engaging means that each person on the team understands the fundamental reason that the team exists. For example, to get a TIPS procedure done that particular day, or to assess inventory in the interventional radiology suite and propose a budget for the next year. It can be a management kind of thing. It can be a quality management thing. It can be a clinical thing. It doesn't really matter. Commitment is part of engaging and means that each of us makes a decision that, yes, I am going to contribute to achieving this goal. And trust comes with time. Trust is not something that's automatic that comes when a team is put together, unless those people have a lot of experience together. But trust will be built over time, and sometimes it's hard to get through this period of time when people don't trust each other and are feeling each other out, and it can make you feel sort of unsettled. But if you work together long enough and agree to the rules of engagement, then trust should follow. Enabling is all about skill. So this means that you have the psychomotor skill and the knowledge, the experience, and the expertise to contribute to a good outcome for that team, and that you're accountable, that you're willing to share that, and that you'll share that in an appropriate manner. Principles means rules of engagement, that you all agree, okay, we'll all talk together. Maybe you agree, we'll all make a plan, we'll have sort of a huddle, and before the patient goes in the room, we'll all talk and make a plan about what we're going to do. Maybe is this going to be a light sedation? Is this going to be a heavy sedation? What kind of equipment do we need in the room? Is this going to be a CO2 case? Okay, I will take responsibility for the CO2. I will teach you how to use it if it's something that you aren't familiar with. And finally, energizing. This is the fuel of the team. These are the people who can be creative, and that comes with experience, right? You're not going to get that from your novice technologists or nurses or NPs or PAs or physicians, because sometimes in our career we don't have a strong enough base to be able to think in a different way. But the more experienced members of the team can do this. Or sometimes the more artistic members of the team who just think in a little bit different way can come up with new ideas on how to do something. It isn't necessarily the use of a wire or a particular tool or balloon or anything like that that constitutes creativity. It may be how the patient's positioned in the room, or that we add music or something as simple as that. We don't want to be responsive to other members of the team, to really look out for each other and know maybe when somebody's stressed out but they are too frightened to say that they're stressed out, when the patient's frightened and maybe needs something that someone else on the team doesn't recognize because they're too busy with managing other equipment. And recognize each other. Give people credit for the good job that they do. Something as simple as saying thank you to each other, thanks for working with me on this case, at the end can go a long, long way. Well, what about some of the destructive behaviors that can occur in teams? Well, unfortunately, we can all recognize some of these, right? A destructive behavior that people can consider fairly benign is ignoring problems. You're thinking it's just not worth it to address this, or I'm not going to address it because no one cares anyway. Nothing's going to happen if I say anything. And then the problem gets bigger and bigger and more demoralizing. So in some way, let's figure out how we can address different problems, whether they're behavior problems, system problems, equipment problems, whatever they are. Pressuring teams to make decisions or to perform more quickly than is appropriate is a very destructive behavior in IR that I have seen a lot. And I always get afraid when a team is being pressured to move too quickly that that's when a mistake is going to happen. And it's easy to fall prey to this as a team and think, oh my gosh, yes, it's 2 o'clock in the afternoon and there are 4 more cases that have to come through, and we're keeping the on-call team here, and feel like you need to run through something. That's when a mistake will happen. So try not to get in a position where you're falling prey to that kind of pressure. Sometimes people will be passive aggressive, right? Let's just call it like it is, and provide incomplete information and let somebody get in a jam or make a bad decision because they lack information that that person may have. That's destructive. Try to understand what someone else's role on the team is. I think, especially for management, sometimes I have been guilty, along with other people, of not understanding maybe what a manager does all day, even though I know they're managing budget and employee evaluations and hiring and firing. And it's true for all of us, right? Each of us doesn't fully understand the other person's role because we haven't walked a mile in those shoes. But I think it would be safe to make the assumption that the role is more complex and involves more than any of us understand, and just take it at that. Playing one member of the group against another is destructive. People can call this the victim, persecutor, rescuer kind of thing. Easy to fall into the role of the rescuer to make yourself look good and perhaps make somebody look bad. But overall, in the long run, it's a destructive behavior. Surprises are also another one. Maybe this is an equipment thing. You know, oh, we don't have that. Or, oh, I forgot to tell you the patient was an NPO, or they got Lovenox this morning. Let's not do that. Let's have a thorough assessment and understanding before the case comes in and not surprise anybody. Makes everybody feel uneasy. Some of the challenges that we face as a team are divergent pathways. So for instance, the RN may report to one manager, the RT to another, and the nurse practitioner or physician to another. So we have different alliances. But together, when we're functioning as a team in clinical practice, we all are accountable to the same person, right? And that person is the patient. Sometimes we have occupational mandates that others may not understand. For instance, what are the floral limitations on a nurse practitioner or PA that would be information that would be useful but not necessarily known to other people on the team. We also have different ways to measure success. So for instance, for one member of the team, it might be, what's the throughput? You know, all right, it takes us an average of 32 minutes to do a paracentesis and 11 minutes to turn the room over and 12 minutes to get the patient down from an inpatient unit to the suite. Another person may say, well, it's how many of these paracenteses we've done without having any bleeding complications. All different ways to measure success, and it doesn't have to be just one method for a particular case or a particular team. This is one of my patients. I take pictures of patients all the time, and usually I just say, oh, I'm just going to take a picture of your arm or your catheter or your device or whatever. And it's funny because most of the patients will say, well, heck no. If you're taking that picture on the road, I want everybody to see me. So it's really the best part of the job, isn't it? Folks like this guy really makes the whole thing worth it. So what about an NP on a team? Maybe you have an NP on a team, maybe you don't. And I'm speaking primarily about nurse practitioners because that's what I know. We all start out as RNs, and we have to have a bachelor's degree before we go into a nurse practitioner program. Most of us have worked as RNs for several years before we go back to school to complete a master's program, which is a minimum of 2 years and typically at least 600 hours of clinical rotations before we get our NP graduate degree. A doctoral education is going to be entry into practice in 2015. Those of us who've been licensed before that will be grandfathered in, but everyone now will need a PhD. Some people are concerned about the doctor kind of title. Personally, I've never used any of those kinds of titles, but there are a lot of folks out there who use doctor who aren't medical physicians, who are psychologists or social workers or physical therapists. So I think we just have to be clear and never misrepresent ourselves. Each nurse practitioner needs to be certified in our specialty area. There is no certification in interventional radiology. The psychomotor skills that we do, we learn on the job. So most of us are adult nurse practitioners or critical care or some other specialty. So what do we do in NP education that's not nursing school? Well, nursing school lays the framework and is the basics, but we do advanced anatomy and physiology, including cadaver labs. We do many, many hours of advanced pharmacology because of our prescriptive authority. We learn the details of physical exam. I already talked about the clinical rotations. And you'll see that nurse practitioners come in with all different initials after our names. So somebody is an FNP, which is a family nurse practitioner, or a PNP, a pediatric nurse practitioner. There used to be a title called adult nurse practitioner, and that title is going away. So you'll see more nurse practitioners in IR who will be critically care trained or primary care in family, similar to a pediatrician versus an ophthalmologist, same kind of thing. So there are all different kinds of programs. So just like you can be an RT and be an MR RT or a CT RT or ultrasound or IR, so can nurse practitioners. Family nurse practitioners can take care of children and adults. Adult NP programs cannot, but they are being phased out. So I think what you really need is someone who has good judgment, good experience, and has the guts to do this kind of job no matter where they come from. Right now, there are over 150,000 nurse practitioners in the United States, and we graduate about 7,000 folks a year. Historically, about 50% of the jobs or a little bit more have been in primary care settings, but that's really changing so that more and more NPs are in specialty practice like IR. We don't really know how many there are. A lot more nurse practitioners working on hospitalist teams in inpatient areas, critical care, nephrology, those kinds of things, but still a large role in primary care, particularly some of the new urgent care centers that are popping up in novel sites. So what about the IR-NP? Well, you say, how do you learn how to do this? And you tell people you learn how to do this on the job, and people think, really? I mean, that sounds sort of maybe a little scary. But how does anybody learn how to do their job, right? And how to learn a psychomotor skill, you learn it by someone else teaching you. There are no formal fellowships or education programs at this time in IR, though we're certainly talking about doing it. There are some graduate students who will do clinical rotations in IR, though typically when an NP is hired into IR, he or she has no formal training in interventional radiology. Unfortunately, not only nurse practitioners, but also some hospitals are a little short to recognize the opportunity that exists in specialty practice for nurse practitioners, but it certainly exists, and we've been in IR for about 18 or 19 years now so far. So what are some of the things that we do? If you don't have one of us in your practice and you think, well, do I even want a nurse practitioner? What would he or she bring to the group? So we do all sorts of things. We see patients in consultation, both inpatients and outpatients. We see patients in follow-up via telephone, telemedicine, in the office, in the hospital. We manage all sorts of complications, the bleeding dialysis catheter, the patient who might have a pseudoaneurysm after an arterial puncture. We perform and assist in all different kinds of procedures and a lot of other stuff that we're going to talk about in just a few minutes. In the beginning, when I went to IR, none of us knew what to do with each other. I didn't know IR. I didn't know any of the tools. And the techs and the nurses had never worked with a nurse practitioner in IR. So it was a little bit of the blind leading the blind, and I think it made it more difficult for all of us to not know that. So there have been days when any of the nurse practitioners might have been choked a little bit by the folks that we work with, and I guess that still happens. Some of the concerns that I think the RTs had in the practice that I first went to were these, and that was that if I was there was going to be less for them, that maybe they wouldn't get to scrub in on a case or have the physician's ear or have that camaraderie during a case with a physician because they were used to being right next to the physician if I was scrubbing in on the case. And we've really learned to do a lot of give and take on that so that there's room enough for everybody. Some RTs also worried, quite frankly, that their license would be at risk, particularly as it concerns fluoro, and that varies from state to state. Some states will allow nurse practitioners to fluoro either with or without additional educational training. Some will not, and so then as a group, you've got to figure out how you're going to deal with that. If the physician is in relatively close geographic proximity, does that mean that the RT can fluoro for the nurse practitioner or not? That's a matter of state scope of practice and state law as well as institutional policy and procedure. The reality for us worked out that we love working together, and each of us contributes a really important piece to working with the patient and making sure that things get done appropriately. I cannot tell you how instrumental RTs have been in my career in teaching me equipment and technique, teaching me radiation safety. I love thinking about different strategies to do something, and it's amazing to me how many different ways there are to do something. I'm sure you've all been through the experience where you learn how to do a particular case and you finally master scrubbing in on a particular case. And then the next great developmental leap is figuring out what to do when things don't work so well, right? And do you have 3 different options in your hip pocket for dealing with a problem? That's when you really feel like you've sort of made it in IR, but that takes some time. If I'm working with you, my fluoro time is going to be better than if I'm working with someone who's inexperienced, because we've learned to work together. You know my next move, and you know, all right, we don't need to have the tour of the body here getting to see the atriocable junction. We'll get up to the right place, collimate, and boom, get an image and end up doing a tunnel catheter with 0.1 of fluoro time. So we come from different backgrounds. Our focus is different, but we can have so much to teach each other. So some of the things that you've taught me are radiation safety, physics. Lord knows, definitely not my specialty area, and I really appreciate that you folks know it. All different equipment, stents, balloons, wires, catheters, everything, as well as strategy. But what can you learn from a nurse practitioner? A lot of the questions that I get from folks like yourselves is about medical management and diseases. What does it really mean when someone has a factor V Leiden deficiency? Or why does someone get a stem cell transplant? And why do we put this catheter in? How does that work? How does pheresis work? What about pharmacology? Thinking about techniques to maybe make it a better experience for the patient and giving them a little benzodiazepine before they come in the room. Well, why not that? And thinking of a different way to do it. We all forget, I think, to a certain degree, that we're in a very familiar work environment. It's second nature to us to be in the suite. But for the patient to come rolling in the room, it's really scary. Smells different, looks different, and there's all sorts of scary equipment hanging there. The patient is worried it's going to get used on them. Manipulation is purposefully crossed out here because it seems like such a dirty word, doesn't it? When I think it's about the same as coordination, and that's nurse practitioners, by virtue of the fact that we're nurses, are typically very, very good at coordinating resources across practice sites. So we'll know how to get a hold of the ostomy nurse or the home care nurse or the hospice nurse. We'll know how to get equipment landed to a patient's home, things like that. That's really important for that patient. Think of the patients with Plerex or Aspira catheters, folks like that, right? There's a lot of coordination required for all of them. What about the RNs? And this is an interesting thing. We've had some RNs in our group go on to nurse practitioner school. A lot of RNs who say, you know what, that doesn't interest me at all. But they're the ones for whom the patient's well-being is their primary concern, managing the sedation and making sure they're safe so the rest of us can concentrate on other aspects of our job. Typically, the RN is going to have a strong background in critical care and med-surg, and they're going to be really, really good at sedation and pain management and not be too afraid to make the patient comfortable or suggest another way of doing things. The RN is the one I turn to when there's a code. You know, let them run it. They're typically good at it, and then you tell me what you want me to do in the code. I think RNs are often underestimated because the glamour part of the job seems to be in the technical aspect, and the RN may be over in the corner monitoring vital signs and watching the monitor and quietly dosing the patient. But we really can't underestimate these people. They're the people who make the case successful, I think. Patient sometimes will say to me, oh, gosh, that was great. I didn't feel a thing, you know. I don't even remember anything. And I say, you know what? I can take no credit for that. That's all in the hands of the nurse who is sedating you. And because the RN is doing that, that frees me up to concentrate on what I have to get done and not worry that I need to be interacting with the patient or assessing them. Someone else has that responsibility, and I can concentrate on what I'm doing. Sometimes we've got a suboptimal situation where the patient hasn't been NPO, but something needs to get done anyway. And I have found that the power of a compassionate nurse is absolutely amazing. Someone who's really engaged with the patient, talking with them and helping them cope with a stressful experience lets us do a lot of things that we wouldn't otherwise have been able to do. Let's talk a little bit about what a nurse practitioner does in the inpatient practice. We admit patients, we discharge patients. We write admission orders and discharge orders. We make sure that the patient gets the right kind of bed, whether it's a 23-hour bed, a tele bed, a critical care bed. We communicate with nursing staff about the patient care. It's not the same as the report that the RN gives, but it may be a point of education for the staff and say, look, we did a splenic artery embolization. Let me tell you about this patient's splenic artery aneurysm and why we coiled it and what you can expect the patient to feel like and why. We deal with the case managers to plan home care and get approval for things like Aspira and Plerex catheters. We are oftentimes the accepting service, and that means we have to take full responsibility 24/7 for the patient. And we collaborate with other services like GI, nephrology, urology to make things happen. We discharge patients, writing their orders, completing a lot of forms, whether it's FMLA, disability forms, prescriptions, making any referrals to home care agencies, things like that, making sure supplies and home care are set up, educating patients and families. What kind of activity can they do when they go home? What kind of diet? What are the things that they should look for and they should call for immediately? What things can wait till the next morning? We also do rounds. So those patients who've had, say, an abscess drain put in or a chest tube, anything like that, patients from the day before who had a new nephrostomy tube or a G-tube put in, we round on all those types of folks. We write all the new consults on inpatients as they come through, and then docs will co-sign them. And the concept of FaceTime is something that I really wanted to talk about a little bit, and that's just being up there on the floors. I cannot tell you, it happens every single week where I'm up on the floor just rounding on the patients that I have on my list, and someone will see me and say, oh, you're here. Do you guys do this? Is this something you could do? And we gain additional referrals by being up and around on the floors and not just sitting in the basement in the dark rooms. Now, that can be a double-edged sword because it does add to more work, but trust me, most of us would want our teams working on us for, say, an abscess drain rather than go into the OR, right? E&M coding is potentially a huge source of revenue for a practice when you've got an NP or a physician assistant, and E&M means evaluation and management. So these are codes that we bill for rounding, for consults, for follow-up. So they're not procedure-based codes, but they're evaluation management. And if you're aggressive about it and you have to meet certain criteria to code appropriately, you could potentially support the nurse practitioner's entire salary by revenue generated with E&M coding. What about in the suite? Well, sometimes we're the primary operator or primary clinician. And again, this is going to depend upon your state scope of practice, institutional policy, the philosophy of the group, and the aptitude for the nurse practitioner to do a case. So when I was at Albany Med, the nurse practitioners were very, very aggressive, and that's because we hired people who had that interest and who were not afraid, and also because the group allowed the nurse practitioner to be that brave by virtue of the support that was provided within the team. And so we did many cases as primary operators: vascular access, drainage procedures, paracentesis, thoracentesis, tube changes like nephrostomy tube changes, and some biopsies like thyroids and random livers. We also performed as an assistant in more complex cases: TIPS, arterial studies, embolizations, really anything else that we had. In the outpatient practice, we have served in many roles, some as simple as sort of interior designer, picking the office space, picking the furniture and the artwork. I mean, it sounds funny, but that's exactly what we did. Figure out where our office should be and what kind of vibe we wanted to have for patients. And, that's really important. It should feel like a welcoming and warm place and not a scary place. We do inventory management, and when you're not attached to a hospital, you really want to be right on with this, because if you need a particular needle and you don't have it in the outpatient practice, it's not like you can go borrow it from another unit or get it from somebody else. You're sort of stuck if you don't have it. What other things do? We make sure patients are booked properly, and we're the ones who set up the template to make sure that happens. So for example, a new consult gets an hour, a follow-up gets 15 minutes, but within an hour block, we'll book 1 new patient and 4 follow-ups, because we've got the nurse practitioner and the physician working side by side. So one is seeing one patient, one is seeing the other patient in 2 exam rooms. You want to ask yourself when you build your practice if you're going to accept referrals directly from patients. Now this may sound foreign, but it's really not. For instance, what if the patient has read about uterine artery embolization on the internet and they want to come in and talk to you about it? Why not? Right? Why not? We do accept referrals directly from patients. The nurse practitioner will help make the decision about who needs pre-visit or post-visit testing, additional PVRs, cross-sectional imaging, blood work, that kind of thing. We make sure that we have appropriate information from the referral source before the patient comes, and typically what we've done is start to build the patient's chart and the note before the patient arrives, so that we're not spending a lot of time either writing or on the laptop in front of the patient trying to build their chart when they're already there. It really helps with efficient throughput. So if a patient is new to the practice, the nurse practitioner will start the consult and sit down, review the information ahead of time, and then walk in the room, and what we'll say to the patient is, this is my name, welcome to our practice. This is my understanding of why you're here. Review everything. The patient can say, yes, that's exactly right. Well, most of that's right, but here's something else that happened. And ask the patient, what are your expectations of this visit? What did you come here wanting to learn or understand or schedule? And they'll tell you, and they appreciate that you've done your homework and that you know sort of the lay of the land before you get too far in. Too many times we go in and we start to explain a procedure before we really know where the patient's coming from. I also explain the role of an interventional radiology team to the patient. Most people, it's not a term that they're really familiar with, and they think, well, how are you? Are you surgeons? Are you radiologists? How's that different? And what should I be able to expect from you? We will do the appropriate physical exam depending upon what the situation is. For instance, veins. We'll vein map patients. We'll review the imaging, mark any veins that need to be marked, and give the patient an estimate. Say if the patient's there for sclerotherapy, I think this is going to take 3 sessions. Insurance won't cover it, et cetera, et cetera. Then we present all this information to the doc who's seeing the patient for the first time. And then they go in and summarize, and we'll make the treatment plan. So the initial treatment plan is, are there even any interventions that are appropriate for us to offer this patient? Maybe the patient is coming in with something that, we thought we could deal with, some back pain, and it turns out, an epidural steroid injection or a kyphoplasty is not going to be appropriate for this patient. And we can't do anything for them. And a lot of times, we feel a little bad about this, but sometimes it's just a relief for the patient. And they say, okay, either nothing needs to be done, or I don't need you, and that's okay. I'll figure out what I need, or maybe, maybe I'm done, and I'll go back to my primary care physician. We think about what, if any, additional clinical studies need to be obtained, whether we need another specialist to consult. Do we need to consult, for instance, radiation oncology, wound care management, a podiatrist, anybody like that? And how do we coordinate with the demands of the patient's other patient's other clinical needs. For example, what if the patient is on sorafenib? And we know that we want to stop sorafenib a week before and a week after, we're going to have to communicate with the patient's oncologist. If we want to stop Coumadin, but the patient has a new cardiac stent, we're going to want to communicate with the patient's cardiology practice to make sure that the patient can safely come off Coumadin and whether they need to be bridged with Lovenox. We'll pre-medicate any patients appropriately, either for contrast allergy, for anxiety, anything like that. Unfortunately, we sometimes get involved in insurance approval, though I clearly view this as a more administrative task, but sometimes you just get called into this, and usually it's to provide some clinical expertise in terms of coding. So here's a typical patient who comes into the office. She's got menorrhagia, urinary incontinence, and pain, and she's coming in for a UAE consult. So we're going to get the notes from the primary care OBGYN. We're going to get any imaging studies that have already been done. Has the patient had an ultrasound? Has the patient had an MR? Is there an endometrial biopsy? Review the history, begin building the note, and figure out, are there any what I call landmines? That is, does the patient have a contrast allergy? Is the patient developmentally disabled, and that might call for a different level of sedation? Is the patient able to make decisions for themselves? Those kinds of things. And during the visit, we're going to ask about the patient's symptoms. I say, this is my name. This is what a nurse practitioner does here. This is what an interventional radiology team does. Let's talk. And whether the patient's in the hospital or in your office, I think it's critically important to sit down. You don't want to talk over someone. It's really intimidating. So I sit down, talk to the patient eye to eye, and try and be, sort of relaxed, make the patient feel like they're not being rushed. Make sure you get a really good history, physical, and talk about symptoms. And let's face it, you got to learn to talk about sex if you're going to talk about patients who have pelvic congestion, patients who have varicoceles, patients who have menorrhagia. Just part of the game, okay? It's part of something that's impacting on the patient's quality of life who have these kinds of problems. One of the things that helps me remember a patient is to remember something little about them and put it in like a sticky note section of the chart. You can do this in most electronic medical records as well. So you might put in there, okay, this is a patient who's the first violin with the local orchestra, and they have 6 dogs. It is amazing how quickly that person will come to mind when you say, oh, it's the violin player. You may not remember the patient's name, but there's something special about them that you remember. And then when the patient comes in the next time, you can say, hey, how are the dogs? Okay, you've just cued yourself to remember, but patients really appreciate that attention to detail. Okay, make sure if you're going to explain a procedure, you know it. That you know how to give the patient sensory information. All right, this is going to feel cold, this is going to feel hot, you're going to feel pressure, any of those kinds of things. That's all information that helps the patient cope with the procedure. They don't need to know you're going to use a guide wire, things like that. They want to know what is the experience going to be like for them and that they're going to be in the room an hour or 2 hours or whatever it is. And you begin to draft a treatment plan. So the treatment plan could include ordering labs. Let's just say this is a patient with menorrhagia who's had an ultrasound that shows a fibroid in the OBGYN office, and that's it. So you want to order the MR, you want to order labs because you know you're going to give that patient contrast. You want to schedule the procedure and an admission if it's appropriate, if the patient wants to proceed, and communicate back to the referral source. Send that whole office visit note. Say, thank you for this referral. We really appreciate it. And learn to send referrals back too. Educate the patient. Send them home with written information or a link to your website with information that they can read after the visit. We send our patients out pre-procedure with the post-procedure instructions so that they have a chance to get ready for what's going to be required after they go home. Okay, so on the day of the procedure, the same woman comes in again. Comes back to the hospital, you walk in, you say, hi, I'm Gail. I met you in the office a month ago. How are the dogs? Blah, blah, blah. Do the informed consent if you haven't already done it in the office. Make sure you've had appropriate witnesses and you've appropriately disclosed and documented the potential risks of the procedure. Write any additional orders that need to be written, say to start an IV, put a Foley in, those kinds of things, and assist with the case. After the procedure, the day after, you're going to discharge them or call them at home, see what kind of recovery they're having, go over medications again, make sure the patient's taking them appropriately, and schedule their follow-up, whether that's 2 to 4 weeks, and then with an MR in 6 months, whatever your practice protocol is. Other roles that we may work on that you may not see because we don't do them in the suites include looking at quality management. So for instance, one of the projects we worked on was what was our diagnostic yield on 18 versus 20 gauge cores when we did random liver biopsies. And we collect the data on that. We are often triaging cases. Cases come through the secretary or through the practice in some way, and the nurse practitioner may make the decision, all right, this one has to go today, this one can go tomorrow, who can wait, who can't. We do all sorts of things that I call tasks. That would be electronic messages or phone message. Somebody needs their FMLA form filled out. This prescription wasn't right, call the pharmacy back, those kinds of things. We manage complications, so the patient who calls and says, I think my port site looks funny, it's red, it's sore, whatever, make a decision, bring the patient in, look at it, and make a plan from there. And then PR, or public relations. Nurse practitioners and physician's assistant, as well as you, are really the face of the practice out there. So anytime we go out, whether it's to go to the cafeteria at work or up on the floors or in the office, we are the face of the practice. Other NP roles. Well, we do education. We teach in nurse practitioner programs and nursing programs. In Albany, a couple of us were on faculty at the medical college. We educate home care agencies, extended care facilities, perhaps about a new device or a new technique. Okay, we're sending this patient out to you with a nephrostomy tube. This is what it means. This is what to look for. Talked about marketing, talked about quality management. Sometimes we're project managers or leads on clinical trials, whether that be an embolization study, maybe it's a device study, maybe it's a symptom management kind of study. We're intimately involved in those clinical trials in academic settings. So why have an NP when you could have another doctor, right? Or you could have somebody else? Well, I think the NP really complements the physician because we tend to be more up to date than radiologists on general medical management, and we have to be by virtue of our licensure and our credentialing. We've got to keep that up to date. So for instance, when new insulins come out, when new anticoagulants come out, we know about them and we usually know how to manage them. It's just what we do. If we needed another doctor, we could hire another doctor. And nurse practitioners are not really what you might call junior doctors. I think we think a little bit differently, and it's a complement to the practice, just like the physician thinks differently, and they're very much a complement to everyone else on the team, including the nurse practitioners. Most of the time, patients perceive us as being more accessible, whether it's the way we talk to them or the time that we have to talk to them, and it's just something that I think comes with the nursing training. What about economics? Can we bill in a practice? Can we generate revenue? Well, we sure can. We bill under our own NPI number. We get Medicare and Medicaid reimbursement at 85% of the physician rate. So 85% is better than zero, right? Third-party payers typically follow Medicare and Medicaid guidelines. So the E&M coding that we talked about before, evaluation and management, can also be a significant source of revenue, outpatient visits and inpatient rounds. There is a billing code called Incident 2, and that only applies when you see a patient in off-site practices and when the physician is not immediately available. So that's not typically a large source of revenue for a practice. The time a nurse practitioner cannot bill is when she is employed by the hospital. So for instance, a hospitalist NP employed by the physician just gets a flat salary, and that's included sort of in the package. But in IR, typically the nurse practitioner is employed by the physician group and then can bill. So there's a source of revenue not only from procedures but the E&M coding, but the other thing is that NPs can free the MD up to do more complex cases. So we're doing something that might be a little more straightforward, a drainage, a catheter. The physician can be doing that many more TIPS procedures, that many more embolizations, or reading out regular body imaging. There are some challenges, of course. One is fluoroscopy. In some states, you need to go through a separate educational program to be able to fluoro. In some states, it's just not allowed at all. So that can impact on your ability to do a case quickly and effectively, depending upon the resources that exist in your practice, how many other RRTs you have, how many physicians you have to be available. So that's something that's really critically important for your group to scope out in terms of the span of the nurse practitioner role in interventional radiology. Some groups just want a nurse practitioner who's going to round and work up patients. For some nurse practitioners, that would be enough. It's not enough for me, but everybody is a little different. Some IR practices say, hey, if you like doing this kind of thing, find your niche and figure out where you want to go on this and do procedures if you want. The reimbursement climate is changing. Right now, we don't see changes in NP reimbursement, but who knows? With physician shortages and ratcheting down reimbursement in radiology, who knows what's going to happen next. There are a lot of opportunities for nurse practitioners in IR. It's a creative, aggressive specialty, as you know. So when I talk to nurse practitioner students about coming to IR, I say, you know what, it is not for everybody. If you have the guts to do this job, it's a great job. But if you don't like not having predictability and rules, then IR is not for you. There are so many different areas we can go to, whether it's learning different procedures, teaching, doing R&D work with different device manufacturers, you name it. And you can have roles in clinical practice, education, and research, which are it's basically the triad of professional practice. So just to talk a little bit about the power of a team, you know, in general, I value very much every single person on the team introducing themselves to the patient and explaining what their role is. Even if it's something as simple as saying, I'm the technologist in the room and I'm going to be running all the equipment. Very reassuring for the patient to know, oh, look, all this stuff looks really complex, but you know how to run it and you'll be watching out for me and make sure it's done correctly. Patients value that so much. At the group I'm at now in Sacramento, the team is really, really good about everyone introducing themselves, and I really appreciate that. Each of us is responsible for the patient's safety no matter what. So whether that means the patient is strapped on the table appropriately or the timeout is done appropriately, each of us has a piece of that. This is one of my favorite quotes, and it really, to me, applies to team building. And it says, if you want to build a ship, don't drum up people together to collect wood and don't assign them tasks and work, but rather teach them to long for the endless immensity of the sea. Right? So really, even though we have the catheter and we have the drugs and we have the fluoro, what we really want is for that patient with cancer to get better, or that patient with cystic fibrosis to feel better. And so that's really what we should all be thinking of, and the other stuff is just the means to the end. This is one of my patients that I've taken care of for a ton of years. I miss him terribly, but it's really all about him and his peers. If you have any questions whatsoever, I am happy to talk to anybody anytime, either via email or via phone. If you think of something tonight, tomorrow, any other time that you want to talk about, or if you, say, have a new nurse practitioner who wants to do a peer-to-peer consult with me, anything like that, please just give me a jingle and I'd be happy to talk. I know I talked really fast, but I wanted to save some time for questions.
Thank you, Gail. That was really an excellent presentation. And I know that I mentioned this to you already, but this is one of those topics that never really gets old. And I'll be willing to bet that all the participants that are on tonight have their own individual issues and their own individual labs. And I think you did a really nice job discussing what those issues can be sometimes. And so I just want to thank you again for a really great presentation. Those of you who are online with us tonight, if you have questions right now for Gail, go ahead and try to chat those in the chat panel. There's a little bar there that you can chat your questions in. I guess I do have a question for you, Gail. You talked about you know, some of the destructive behaviors that can go on in labs, and I guess I would just maybe ask you to maybe give me your perspective. Let's say, you know, there's a team member that is sort of, you know, exhibiting some kind of destructive behavior. How would you handle that? Can you just give us an idea of how you might handle that with that patient or that person?
Sure. If it's in the middle of the case, I try and refocus that person back on the patient. So let's just say a team member comes in the room and is like complaining about, you know, their husband or their wife or something and just sort of mouthing off, and the poor patient's laying there. I'll just say, hey, Joe, did you know, like, Mary lives in the same town as you, or just like completely change the conversation and have it focus back on the patient without confronting the behavior head on, because that's not the time to do it, not when the patient's in the room. And then after the case, I just pull them aside one-on-one, and I think it's really important that it be done privately and someone not feel that they're accosted, but feel that they're respected. And, you know, say something like, gosh, you really seem stressed out. Are you okay? You know, I know you came in the room and you mentioned this, and I was concerned about you. You know, sometimes people are dealing with stuff and their behavior comes out in a really negative or aggressive way when they're really frightened. So I just try and always assume that everybody's got their stuff that they're dealing with, you know, whether it's a sick kid or a marriage gone bad or whatever, and that may be playing into it, and say, come from a point of concern. You know, are you okay? And then if, yeah, I'm okay, what's the big deal? Then you say, all right, well, when you came in the room and you said this, the patient maybe thought that you weren't paying attention to them because you were talking about what was going on in your personal life. And I think that made the patient nervous or frightened. You know, stuff, that's how I do it.
That's great. That's great. I think, you know, in our lab, I think it's, you know, I certainly look to, you know, some of the people that I work with and that maybe are I don't know, the people that I see that are doing like a really nice job or going above and beyond. I mean, those are the people that I sort of want to model my practice after. You know what I mean? So I like to talk to them or see if I can, you know, kind of pick their brain and do some things like that. But it's difficult sometimes, especially with those people that are sort of tough to deal with. But does anyone have any questions? Does anyone have any issues? Oh, looks like we do have something. What is your recommendation to facilitate coworkers, mostly at the end of the day, to proceed with the last cases? I have some coworkers who tend to slow down at the end. How do you keep them motivated?
You know, yes, we have all seen that. You know, everybody gets tired. I think you can never fail by bringing it back to the patient and saying, hey guys, you know, I know we added on this paracentesis, and you know, this is John Doe. We've done him before. He's going to feel so much better after we do this because you know he is in so much less pain after we do this. So let's see, can we get him down? And you think we can knock this out together? I try and bring it back to a patient outcome.
That's great. That's great. I love that answer. Did that answer your question, Megan? I think so. Does anyone else have anything for Gail at this time?
There's a couple in the question area.
Okay. Can you see those, Gail?
Oh, yeah. Thanks, Megan.
Can you see
the question about team members who have a lot of ideas but don't follow through? You know, it's hard if you are not the manager, but I don't think you have to be a manager to say to somebody who's not following through, hey, can you get me that article that you were talking about? You know, you suggested that buffering lidocaine would help, but I don't know anything about that. Can you maybe get me that article? You know, be very specific in what you're asking them to do. If it's more global, it's easier for people to slough off, or if the task seems too overwhelming, it's easier to sort of blow it off. It's sort of like all of us have our to-do list, and sometimes my to-do list is so detailed, but it makes me feel better because I can cross things off. So instead of saying I have to write an article, I'll say, okay, do the literature search, organize the files. You know, I break it down into more measurable, achievable bits, and I think sometimes that helps when someone has offered to do something and not really followed through. Say, you know what, I know you're really busy, but you know, maybe at the end of today, can you and I sit down and talk about how to buffer lidocaine and maybe figure out together what cases we might want to try that in, make it really, really specific.
I think we have time for one more question.
Sounds good.
What behaviors impact most on team satisfaction and morale? I think positive behaviors and showing appreciation to each other. Even when, you know, it's one of those cases where you think the dogs are barking. You know, it's 2 o'clock in the morning and it's a GI bleeder and everybody's tired and that kind of thing. Appreciating each other and saying, you know what, I know you're tired. I know you drove an hour to get here. Thank you for being here. Thank you for doing this case with me. And I think just simple appreciation of the different members on the team, and you don't even have to be more specific than that, impacts on morale more than anything else, sort of recognition of the contribution that each person makes.
Absolutely. I totally agree. I think that makes people feel valued.
Yep.
So that's awesome. Well, guys, I think we're going to go ahead and close it down. She did, you do have her email there and her cell phone, so if you guys want to jot that down, if you have questions beyond this. I do wanted to say a quick couple of things before we would close it down. You will get an email once at the conclusion of this presentation. You will receive an email. Actually, it'll come tomorrow with an evaluation. You'll need to fill out that evaluation and send that back, and then that's when you'll get your CE certificate. Okay, so make sure that you do that. Otherwise, you will not get the credit. Also, this is, again, on demand, so if you decide that you want to go back to this presentation and kind of pull some things out, you're able to do that. And if anyone has any questions about that, either let Karen Marshall or I know, and we can certainly make sure that you can get on and do that. Lastly, I think it's important that when we're done here that you close down your browser for attendance management type of issues. Please make sure that you close down your browser so that we know that you are here. Just remember, we do have an upcoming webinar. The next one is December 10th. And again, it's going to be presented by Kathy Duncan, so we're looking forward to that. And I just want to say again, thanks to everybody who participated tonight. And again, thanks, Gail, for doing such a nice job with this presentation. Thank you, guys.
Thank you. Take care, everybody. Bye-bye.